Now have the pleasure of inviting Dr. Dean Foti up to come speak next. Dr. Foti is a clinical assistant professor with the Department of Neurology at UBC. We know him as an excellent educator. His experiences clinically are very highly sought after by fellows and residents and other physicians. But in addition to that, he is a clinician who, of course, works in the clinic. And in fact, he's the longest-serving clinician who I think is still practicing in our clinic with well over 20 years of experience working at the Alzheimer's clinic. So Dr. Foti is just getting mic'd up, and it will be very appropriate then that we will be hearing from him next, and he'll be giving us an update in terms of the current treatment options for dementia and mild cognitive impairment. Dr. Foti.
Thank you, Dr. Lee. It's a pleasure to be here today. I think they're just getting my slides together. I get to be good cop and bad cop today. So I get to tell about things that we know work, and I also get to tell you about things that you shouldn't be taking. And then there's a big category of things we just don't know anything about. And that's all going to come back to some of the things that Dr. Foti spoke about, which is sort of quality of life in dementia. Bottom one. All right, so we're kind of going back in time now. I'm going to take you back to the 1990s, because these are when our last real therapies, or the first therapies that came out for Alzheimer's disease first were developed. So these are the approved therapies for Alzheimer's disease in Canada. We have the cholinesterase inhibitors, of which there are 3 of them, donepezil, rivastigmine, and galantamine, and their trade names you can see beside them. And then there's another drug that's in a different class, a different chemical compound called memantine, or Ibixa, goes by a different name called Namenda in the United States. And these are the therapies that we have that are approved for treatment of Alzheimer's disease, and we know we have appropriate trials with them. So just to take you back, so this is going back to about the time that I started at the clinic, is when these drugs started to be developed. And we've been using them since then, with the last sort of approved therapy being the memantine in about 2004. So what they do is that this derives from an observation that the chemical acetylcholine, which is a neurotransmitter, which is how brain cells talk to each other, in the synapse. So this is called the synapse, is where they connect, and they release a chemical that interacts with receptors, and that causes an electrical change, and that is how our brain cells talk to each other. So what happens is that this acetylcholine was found to be low in the brain in patients with Alzheimer's disease. So increasing it was felt to perhaps have some benefit. So what we see happening here is you have the drug in the system, and it gets broken down by an enzyme called acetylcholinesterase. And if you block that enzyme, which is what these drugs do, you then raise the level of the acetylcholine, so it means that there's more communication happening. And this is how the drugs work, by raising the chemical level in the brain. So using these drugs, we can then try to have an impact on the disease. These drugs were studied extensively in the 1990s, and there's more than 30 randomized placebo-controlled trials with these medications, and they're more or less universally positive, which is a big change from all the other drugs that have been worked at since that have all failed with a very similar type of study design. So almost all the recommendations of various governments and organizations say that these 3 cholinesterase inhibitors have demonstrated efficacy for mild to severe Alzheimer's disease, and a trial is recommended for most patients with Alzheimer's disease, assuming there are no specific contraindications. And this is from the Canadian Dementia Guidelines over a number of years. This was the 4th meeting, the last one, and it comes with the grade 1A recommendation, means it's the highest level of evidence that you can have. The other important comment is that combination therapy with the drug memantine, which works by a different system, seems to be reasonable because it's working on 2 different chemical systems, but the actual scientific evidence is not strong enough to make a recommendation either for or against it. So you can use it together or separately, but there's really not enough guidance in proper studies to indicate whether it's useful. So just to give you an idea of what the expectations are from these medications, this is an example of one of the trials, one of the drugs called galantamine, and the results of all the three different drugs are very similar. And what it does is this is a cognitive measure, and the blue line here is a placebo group that's gradually declining on this cognitive test over a 6 to 12-month period. And then when you put somebody on medication, there's a slight bump in the cognitive scores, and then over 1 year there's a difference in outcome between the treatment people and the people who are on placebo. And if you start somebody, let's say 6 months down the road, you see that they then stabilize. If they're on placebo for 6 months and then go on the drug, it kind of stabilizes things out. So the important thing is that they never really catch up to the people who are started at the beginning. So the idea is once you have a diagnosis, it's good to start therapy earlier. So that's one of the principles that we try to follow in treating Alzheimer's disease. This is another example of a functional measure. So this is an activities of daily living scale, how people dress, use the telephone, follow their medications. And you can see that patients over a 6-month period, if this is now moderate to severe disease, so people with more advanced Alzheimer's disease, they're able to sort of stay the same over a 6-month period, whereas the people who are on a placebo decline over a 6-month period. And there's a significant, meaningful difference 6 months later. So this is kind of the two areas, sort of stabilizing cognition and stabilizing function that's important with the medications. Now, these medicines are not a cure. We call it modest benefit. They don't stop the memory loss. They don't reverse, language or word-finding problems. But it lets people hold their own for maybe 6, 12, sometimes 18 months, depending on the specific response of that patient. And this is a meaningful outcome for families. And what people often ask is, well, what do these numbers mean for a person in their everyday life? Well, there were some studies that tried to look at that. So this is some data from one of the galantamine mild to moderate Alzheimer's disease trials that looked at caregiver time. So this is a placebo-controlled trial, and it shows that people who, the caregivers of patients who are on placebo, that's in the yellow, they were spending after 6 months, about 30 minutes more per day in caregiving duties. Whereas the patients who were on active treatment, in this case galantamine, after 6 months, they were spending about 30 minutes less. So they kind of gained about an hour's worth of caregiving time per day in terms of what this translates to have stable function and more stable cognition. So this is kind of the background of the drugs that we've been using for over 20 years now. And unfortunately, nothing better has come out that has shown this sort of same consistent benefit. But it certainly is not a cure for things. We have also learned that these drugs are useful not just in Alzheimer's disease, but also in other types of dementia. So patients with Parkinson's disease and dementia, patients with dementia with Lewy bodies, which is a mixture of Alzheimer's and Parkinson's changes, as well as in people who have a mixture of vascular and Alzheimer's changes. Unfortunately, these drugs are not useful in everything. They're not useful in writing tests or normal aging. Multiple trials have not shown benefit in preventing conversion from mild cognitive impairment into Alzheimer's disease, so we don't use them in general for most patients with mild cognitive impairment. And they're not useful in the frontotemporal dementia patients, like the Pick's disease type patients. So the other drug that we use, albeit less frequently than the cholinesterase inhibitors, is a drug called memantine, which works on the glutamate system in the brain, which is important for communication between cells. And it does seem to have a role in advancing Alzheimer's disease. So the studies in mild to moderate disease are not that useful or positive, whereas patients who have moderate to severe disease, which usually means a mini mental status examination score of about 15 or less for most patients, or when people need more everyday support for their basic living skills like dressing or hygiene, is usually when we think about initiating the memantine. And we also use it sometimes combined with a cholinesterase inhibitor, sometimes as monotherapy. One of the benefits seems to be it helps to reduce mild agitation with patients. So we do find it helpful for that behavioral outcome. So now I'm going to move on to sort of a list of things that may be helpful, probably are helpful, and a lot of what we don't know. So treatments likely to be helpful and probably not harmful for Alzheimer's disease dementia. So these are this is for people who have a dementia already, not for people at risk of dementia, not for 20, 30 years before the dementia starts. So we do know that, aside from the things I've already told you, that aerobic exercise does have an impact on functional progression in Alzheimer's disease. We do know that social interaction also seems to have an impact on functional progression. And there's probably less solid evidence, but treating vascular risk factors probably also has a role in preventing progression, because we know that there's an interaction between vascular changes and Alzheimer's changes in the brain. So if you can reduce the chance of a stroke, then you're probably going to reduce the chance of the Alzheimer's progressing. And there are some studies going on. For example, we're now doing a trial using a sartan medication in Alzheimer's disease to see if that has a more beneficial effect on preventing the progression of Alzheimer's disease. So there's also a number of treatments that have been reasonably studied. So these are treatments that have had a number of what we call these placebo, which is like the sugar pill, blinded studies, and have been found to be essentially ineffective. So we know that there's been some studies with ginkgo biloba, which really show no benefit in Alzheimer's disease and may increase your risk of bleeding. High-dose statins, so using drugs like atorvastatin or simvastatin at high dosages, has not been beneficial in a few large trials in Alzheimer's disease. But on a positive note, there's a lot of bad press about statins causing problems, and none of these trials showed that the statins actually caused any worsening of memory function. There's just really no difference between placebo and active treatment. So we don't recommend those for treating Alzheimer's disease. Vitamin E had some excitement in the late 90s, but then further trials showed that, in fact, there was no real benefit from high-dose vitamin E, so we don't recommend that. There was already a question about anti-inflammatories, and there have been trials involving naproxen. There have been a smallish ibuprofen trial from about 10 years ago that didn't show any benefit. That was about 800 milligrams a day of ibuprofen. And also trials using higher doses of steroids like prednisone have all been negative in treating Alzheimer's disease. So this is not using it 30 years earlier, but when you already have the condition, it doesn't help. Immune globulin, again, some initial excitement, and then a larger trial that showed no benefit. Huperzine A, which is sort of does a little bit of effect on the cholinergic system, was not helpful. And then omega-3 supplements as well have not been shown to be beneficial in treating Alzheimer's disease. So these things probably don't work. So that brings me to the next category, which is a large category that could probably fill multiple slides. And this is sort of be the poster child of this information. So this is the Bredesen diet program, which is essentially putting the brain into a ketogenic type of state, so avoiding glucose. We talked a little bit about this in the first half of the meeting this morning. This is a plant-based diet that has some overlap with what we see with the Mediterranean diet, but is much stricter and not a lot of fun to be on. So that's the problem with the diet, in my mind, is that it's not a lot of fun. And we heard that fun was really important in dementia care. So this is tough to follow. There's a lot of work. It also involves a fasting state of about 12 hours, which is also a bit of a challenge and not that People who are hungry tend to be a bit irritable. So I think that's something that really needs to be taken into account when understanding quality of life in dementia. So the research behind it is actually quite interesting. There's good sort of animal science, and Dr. Bredesen is actually a very qualified researcher at UCLA, a good institution, had a good training at UCSF as well, worked with one of the Nobel Prize winners, Stanley Prusner, so has a good pedigree. But the problem is that the results of the diet are just very anecdotal. We're looking at a dozen patients, little groups of patients, some that apparently got better, but there's no control group, and we really don't know what's going on. And there hasn't been a proper analysis of a large group of patients with a control group. And that's the real problem with almost everything that's going to come up on the next slide, is that we really just don't know. So these are a list of things of uncertain benefit. So there's a lot of interest. We heard about coconut oil already. That's the sort of medium chain triglyceride. And we are doing the MINT trial here, which you heard about as well. We were all excited about a coconut oil trial happening in South Florida starting about 5 years ago, which surprisingly was terminated, I think, last year because they couldn't recruit enough people. Because everybody said, why should I be part of the trial? I'll just take the stuff myself. So it was really actually hard for them to recruit for the trial. So there is no data of significance of people control in coconut oil. Having said that, it's probably fairly harmless. I have a number of patients who've been on it, and I would say in general they're a bit more attentive after about a month or two, but then it kind of fades away. And I personally haven't seen any change in their dementia trajectory over a few years of being on coconut oil. So I'm not that optimistic that it's going to have a meaningful effect over a longer term. And that's another role where our clinic comes in, is we now have a larger electronic database, and we're able to track people who are taking coconut oil, people who say they're following the Bredesen diet, and be interesting to see with that electronic data in our clinic whether we can see a difference in the trajectory of those people. So even though it's not a blinded trial, it might be a good observational trial of people who are following that diet. So the same thing can be said about curcumin and turmeric. And there's a whole bunch of other things along that left-hand side of the slide. The cannabinoids are interesting because they can they don't seem to be detrimental for memory, so this is like CBD oil, but it might help anxiety. So I do have some patients with using CBD oil for anxiety, and it does seem to be well tolerated. There have been trials in Toronto for deep brain stimulation. Again, some earlier excitement, but I would have to say that over the longer term, I'm not seeing much effect from the DBS, and then a whole bunch of stuff on the right side. So just to finish off, this is sort of prescription for mild cognitive impairment. We could just call it for better aging. These are the size of the pictures is probably their relative importance. Aerobic, some type of physical activity is by far the most useful thing for prevention of cognitive decline. I agree fully, sort of outdoor walking is great, but there could be all kinds of other aerobic activity that can be helpful. The Mediterranean diet, again, overlapping with some of the Bredesen work, but not in as strict of a fashion, so more fruits, vegetables, nuts, olive oil seems to be good for the brain. There's reasonable long-term data in big studies that suggest people who follow that diet do have a lower rate of progression of cognitive decline. Controlling vascular risk factors also seems to be important. Down there in sort of the middle bottom, you see people playing a game, card game, socializing. So social contact also seems to be extraordinarily helpful for preventing cognitive decline, particularly if it involves some games or an aerobic activity. That would be probably the best outcome. And then the smallest box is the cognitive activity. That seems to be probably, has the least positive evidence to say if you do crosswords, Sudoku, or the other games that they're not, you can do them if you like them, but otherwise they're not that helpful. So my general comments for all of these unknown things is, if it doesn't cause a lot of hardship to your everyday life, go ahead and do it. If it doesn't cause you financial strain, you're not, you're depriving yourself of some in-home support or meals or outings, then go ahead and do it. But if it is impacting you financially and in terms of your lifestyle and enjoying life, then there's no sufficient evidence to participate in these activities. And thank you.